The liver is well supplied with nutrients and oxygen, mainly by the portal vein and the hepatic artery. But blood flow to and from the liver can be altered. Vascular liver diseases are disorders of the hepatic vasculature that lead to obstruction of blood vessels in and near the liver.
Vascular liver disorders are due to alterations of the inflow or the outflow, mainly from the venous system, and this may cause alterations in the function of the liver or in the portal pressure, which is heightened and gives portal hypertension complications.
The most frequent vascular liver diseases affect the venous circulation. They are Budd-Chiari syndrome, portal vein thrombosis, and the newly defined entity of portosinusoidal vascular disease. These will now be further explained.
Vascular liver diseases share similar causes but with different prevalence. The most common cause of these vascular liver disease are myeloproliferative neoplasms, which give thickened blood due to an increased amount of platelets or red cells. This is the most frequent cause, but there are other acquired causes.
Apart from myeloproliferative neoplasm, vascular liver disease can also be caused by inflammatory diseases, paroxysmal nocturnal hemoglobinuria, inherited diseases, as well as any form of thrombophilia.
It is very important to try to identify all of these causes, because it seems that when you treat the cause, you also partly treat, at least, or mainly completely treat the liver disease. So this is why it is so important to collaborate with internal medicine hematologists to find that cause.
Budd-Chiari syndrome is a complete or incomplete occlusion of the draining blood vessels of the liver. The disease is rare. Its prevalence is estimated at 1 in 50,000 to 1 in 100,000. The cause of primary BCS is thrombosis in the hepatic veins or the lower section of the inferior vena cava. Rarely, secondary BCS due to compression or invasion of the vein by a tumour occurs. Budd-Chiari syndrome frequently occurs in connection with risk factors from the hematopoietic system. The most frequent is myeloproliferative neoplasm. There are other rare causes for BCS, such as PNH or other acquired or inherited thrombophilia. Complete screening of causes is mandatory in every case.
Main symptoms of Budd-Chiari syndrome are the presence of ascites, abdominal pain of the right upper quadrant due to hepatomegaly or ascites, and usually associated to preserved liver function, but in case of acute Budd-Chiari syndrome, it can be associated to high transaminase and low prothrombin time. BCS should be easily diagnosed with Doppler ultrasound, but the radiologist really needs to be informed of your suspected diagnosis. And then you can complete the exploration with a CT scan or with an MRI. It's very rare to need to do a liver biopsy for Budd-Chiari syndrome, and usually it's quite dangerous and should be avoided. The main treatment of Budd-Chiari syndrome resides on anticoagulation, which needs to be urgently installed and probably a lifelong treatment. In fact, adding to anticoagulation, you start treating symptoms, treat ascites and portal hypertension, and if you have found a cause, try to treat the cause.
Radiological techniques can help to reopen veins that were recently obstructed or narrowed. If recanalization cannot be obtained, another option is TIPS, a transjugular intrahepatic portosystemic shunt, which connects the hepatic veins with the portal vein. And if none of these treatments are effective, which is now rare, liver transplantation may be necessary.
Complete resolution of symptoms is usually acquired with these therapeutics. Patients go back to a normal life after several months. It can take some time, but after several months, they go back to a normal life. But it is very important to continue follow-up because these treatments have to be surveyed, and also there can be modifications of the liver that need to be observed.
Portal vein thrombosis means formation of a thrombus within the portal vein and/or their right or left branches. It can extend into the mesenteric or splenic veins. Occlusion may be complete or partial. Portal vein thrombosis may occur associated to cirrhosis or malignancies, but also independent of these. Thrombophilia may be a reason.
Any increase in hypercoagulability can lead to portal vein thrombosis, and generally it can be associated to other causes. Like for portal vein thrombosis, it is often associated to a local cause, like an infection or inflammation of the gut, which can lead to portal vein thrombosis associated to this hypercoagulability state. That's why you have to look and to search actively for all of these causes.
Portal vein thrombosis can occur and be completely asymptomatic, but symptoms due to gut ischemia or hypertension in the portal vein are more common. These are intestinal ischemia, esophageal varices, and splenomegaly.
It's very important to diagnose portal vein thrombosis because its main complication at the acute phase is the extension of thrombosis to the mesenteric veins, which will lead to mesenteric ischemia and infarction, which is, of course, life-threatening.
Portal vein thrombosis has to be diagnosed with a 3-phase injection CT scan. Doppler ultrasound can lead to the diagnosis by detecting lowered or missing blood flow in the portal vein, but CT scan has to be secondarily performed for confirmation.
The major treatment, again, of portal vein thrombosis is anticoagulation, which should be urgent and systematic in acute portal vein thrombosis, and which probably needs to be prolonged in patients with chronic portal vein thrombosis. There is recent data saying that almost all patients should be treated with anticoagulation, and this should be discussed in a multidisciplinary team. Further on, it's important to treat portal hypertension complications, and for example, with either beta blockers or variceal band ligation to avoid upper GI bleeding. And finally, once again, it's very important to treat the cause of the disease to avoid other complications.
Portosinusoidal vascular disease, abbreviated PSVD, was formerly known as idiopathic non-cirrhotic portal hypertension. It is induced by various intrahepatic and extrahepatic etiologies. PSVD is sometimes associated with autoimmune diseases, but the pathophysiology remains unknown. Similar prothrombotic factors, but also toxic or inflammatory conditions, can be encountered.
It is important to identify PSVD because it will affect younger patients and with very severe portal hypertension, and this is very particular to be differentiated from cirrhosis. And it's important because treatments will be different and follow-up will be different than cirrhosis. So we really need to have an eye on that disease and an expert eye. So diagnostic of PSVD implies a liver biopsy because and an expert liver biopsy, an expert reading liver biopsy, because it has to show that there is no cirrhosis. And of course, there are specific lesions on the liver biopsy for PSVD, which are alterations of the portal venules, mainly, or of the architecture, but without cirrhosis. And there are specific signs of portal hypertension that are included in the definition, mainly esophageal varices or portosystemic collaterals. Elastography is very useful to differentiate cirrhotic patients to PSVD patients because in PSVD you have a portal hypertension associated to a low liver stiffness. This is opposed to patients with cirrhosis who have portal hypertension with a high liver stiffness. There is no specific therapy of PSVD, but there is treatment for symptoms. And once again, you have to treat portal hypertension symptoms with beta blockers to lower portal pressure, visceral bending ligation when necessary. And if this is not sufficient, maybe a TIPS can be needed once again, or a liver transplantation. It is once again very important to treat the cause of PSVD. There is still a big question on anticoagulation benefit in these patients, and there is an ongoing randomized study on this question. Other vascular liver disease exist. They will affect mainly other vessels. One important is the sinusoidal obstruction syndrome, which is mainly due to toxic chemotherapy, which has been described. And there are also diseases affecting the artery, the liver artery, such as Weber-Christian disease or ischemic cholangiopathy due to alterations of the hepatic artery.
Vascular liver disease frequently occurs in childbearing age. Most patients with vascular liver disease likely benefit from anticoagulation throughout pregnancy and the postpartum period. The risk of miscarriage and premature birth remains heightened, but consistent management can contribute a lot to a successful pregnancy.
Recent studies have identified that it was absolutely possible to have a normal pregnancy in vascular liver disease, which was a very important point because for many years it was contraindicated in these diseases. The important point is to have a stabilized liver disease condition. And also to have a very large cooperation between the obstetrician, the hepatologist, and the hematologist or the internal medicine, and also to adequately manage anticoagulation during pregnancy, which usually has to be continued. In case of pregnancy, but also in the other situations of vascular liver diseases, it is very important to collaborate with patients and patients' association. And indeed, patients can be very helpful to assess, for example, the quality of life of patients, their problematics, their social problematics, and to include them in the therapeutic program, either with other patients' association or with an advanced practice nurse or with a psychologist, and to have a team building around this patient's management. Because we have to treat for a long time patients who are very active, young, working, and who have a lot of projects in their life.
Vascular liver disease is a heterogeneous group of rare diagnoses requiring specialized knowledge. Therefore, it is recommended to link patients to a specialized center or at least to discuss the cases with specialists. This is possible via the ERN Rare Liver, the European Reference Network on Hepatological Diseases.
We're really on the right way with already very important research that has been performed during the last 30 years. Now, the collaboration with patients' associations and newly built networks such as Valdi Group and now ERN Rare Liver really brings us to important new quality of data and quality of research for these vascular liver diseases.